Thank you, everybody. Good morning to everybody. It's a pleasure to be here and speak with all of you. I'm going to take you through the development of a new patient-reported outcome instrument to assess diabetic retinopathy treatment experiences. I did not do this alone, so I listed all my co-authors here. So most of you are aware that diabetic retinopathy is a common vision-threatening condition that substantially impacts overall health-related quality of life. It's particularly true in PDR, advanced disease of diabetic retinopathy. So anti-VEGFs and PRP have been shown to improve visual acuity in patients with PDR, but few qualitative research studies describe the treatment effects from a patient perspective. Patient-reported outcomes are a good way to gain insights into patient function and well-being following treatment, but to date, no content-valid PRO instrument has been developed to evaluate the effects of treatment on symptoms, functional impacts, and health-related quality of life in patients with DR. So in this study, we describe the development of a de novo PRO instrument to assess symptoms, impacts, and health-related quality of life in patients with PDR who are receiving treatment. So we first did a literature review to identify qualitative research that describes the patient experience with DR. We use this information to develop a preliminary conceptual model of disease. We then interviewed 3 clinicians to further do a concept elicitation and get additional feedback on concepts identified in the literature review. We identified existing PRO instruments used in PDR and other ophthalmic conditions, and we selected key ones that we identified as being relevant to map against the preliminary conceptual model of disease. And this informed the development of a draft PRO instrument. I'll skip around here. So we did a few rounds of patient interviews here to further refine the PRO instrument and our conceptual model of diabetic retinopathy. So a little bit more details on the concept model development and conceptual model development and the evaluation of conceptual coverage of the selected PRO instruments. Looking at the literature-based conceptual model, we identified 84 concepts from PubMed by reviewing 1,754 articles. We identified 22 concepts from online resources. We used four websites, which included patient advocacy organizations, medical organizations, and online forums. And then we identified 3 concepts from the clinician interviews that I mentioned earlier. Putting these all together, we had 106 concepts included in our preliminary conceptual model. So we also identified 12 PRO instruments from PubMed with review of 409 abstracts, 10 PRO instruments from clinicaltrials.gov from a review of 363 records, and an additional 1 PRO through manual search. Of those that we found, we selected five instruments, which included the NAI-VFQ-25, the Impact of Visual Impairment Questionnaire, the Retinopathy Dependent Quality of Life Questionnaire, the Limited Luminescence Questionnaire, and the RETCAT. So we mapped these against our preliminary conceptual model and when we did that, the RETCAT demonstrated the greatest conceptual coverage across symptoms and impacts in subdomains, but did not adequately cover concepts related to the treatment experience. So this informed the development of our preliminary diabetic retinopathy scale, which included 4 domains, including daily activities, emotional impacts, social impacts, and vision problems. Examples of these are presented below. So our round 1 demographics and clinical characteristics of our interview patients for round 1 and round 2 patients were mostly consistent. The mean age was 53 years. Most were Black or African American, and the mean years since PDR diagnosis ranged from 6 to 8 years. You'll note that in round 1 we had 40 patients that were interviewed, and in round 2 we had 30. Those 30 that were included in round 2 were also interviewed in round 1. So we revised the preliminary diabetic retinopathy scale iteratively based on patient feedback. Our round 1 patient reported that instructions, items, and response options of the DR scale were well understood. but they propose modifications to reduce the redundancy and improve clarity and interpretation and relevance. So we revised the questionnaire to include 4 new items in the daily activity scale, 1 new item in the emotional impact scale, and we added a new 5-item treatment experience scale. We also excluded the social impact scale because of irrelevance due to COVID. So that was unfortunate, but we had no choice. So our round 2 interviews included, based on the round 2 interviews, we did additional modifications based to suggest that we should improve the clarity and the interpretation. And our final scale included 85 items, spanned 4 scales, including daily activities, emotional impacts, vision problems, treatment, and treatment experience. Our final conceptual model included 3 domains, including symptoms, impacts, and managing the disease. There's a lot of information on this slide and the ones that follow. So, but for now, you'll note that the ones highlighted in green were added to the conceptual model following our patient interviews. So we see that we can note that red vision and dizziness were not previously associated with PDR, but were reported by our patients. There are also a variety of eye problems that were reported by our patients, as you'll see the list in the middle there that were not previously reported. For impacts, we note that there are a number of concepts that were identified in the literature that did not come out of our patients' interviews. These include handling cash, feeling like a burden, and decreased socializing. There are some others on this slide, but I won't go through all of them. We did add a few more concepts from our patient interviews here: walking, riding, concerns for future worsening symptoms, loss of independence. The managing disease domain highlights the complexity of managing these patients. I think I'll highlight the treatment effects here, where a broad range of concepts emerged from our patients with worsening vision or eye problems, no change, or improved eye problems and vision. So in conclusion, a robust, comprehensive PDR-specific PRO was developed to evaluate symptoms, impacts, and health-related quality of life in patients with PDR who are receiving treatment. We feel the DR scale demonstrates sufficient granularity to evaluate clinical and functional benefit of PDR therapies. And the treatment experience scale was a unique component that assesses the experience of patients receiving treatment of PDR. Further refinement of the measure is warranted, though, through a standalone study to confirm the scoring. And also, it is a fairly large questionnaire at 85 items, so we may want to find opportunities to reduce it, and also to evaluate psychometric properties. Thank you.
Thanks very much, Stephen. Terrific effort. I'm curious, as you engage on your validation study, what clinical endpoints are you looking to validate against? What is the clinical benefit? Because I think this is sometimes a challenge that we face when we're developing what we think are brand new measures. What clinical benefit are you hoping to correlate the PRO with?
Yeah, I mean, this is in the context of treatment. So we would want to see that if you improve things like DRSS score or even vision, that you see a benefit in the patient's experience itself. So if you don't, then there's something wrong with your measure. So, we will kind of discuss that a little bit more, because I think there's things like contrast sensitivity even that you can include in that, the things that are really impacting, because really what the expected treatment benefit that we're evaluating here was the different types of treatments. For example, anti-VEGFs, which preserve the peripheral vision, and PRPs, which destroy it. So we want to be able to capture the nuances there as well. So there are a variety of things that we would have to look at to validate it.